So it will not surprise you that we can break arrhythmias down into bradycardias and tachycardias. Bradycardia is slow heart rate, tachycardia, apparently fast heart rate, okay? We're going to start with the bradycardias, and of course we're going to start with the fact that the sinus node sets the heart rate, right? And when we increase the rate of rise of phase 4 of the action potential in the SA node, we increase the heart rate, okay? And I think that should make sense because what happens is we repolarize, we come down, we open our pacemaker channel slowly opens, and as it slowly opens, you let more and more sodium into the cell with potassium going out. The net effect is to depolarize, and your voltage goes up, and the faster that happens, the faster you hit threshold and throw the next beat, okay? So we rise until we hit, right around where we start to see this curve up and our T-type calcium channels kick in our SA node and AV node, and then our L-type calcium channels kick in at a little bit less negative voltages, and the calcium channels carry us up through phase 0, through the upstroke of our action potential, okay? And the rate of increase is dependent upon your autonomic nervous system. So let's take a look at our parasympathetic side. We have acetylcholine released from parasympathetic nerves at the SA node. The acetylcholine binds to M2 receptors. That activates a G protein, GI. GI inhibits adenylyl cyclase. It also opens the ACH-gated potassium channel that you see here. So if I'm letting potassium out during phase 4, this rate of rise becomes slower because we have potassium pulling our voltage down toward its equilibrium potential, minus 95, and our pacemaker channel and a few of the other things that are active during phase 4 have to pull up against that, and the rise becomes slower. So it becomes more difficult to hit threshold, and it takes a longer period of time to hit threshold, okay? In the meantime, our cyclic AMP goes down because we've inhibited adenylyl cyclase, and our pKa activity goes down, and that means our pacemaker channel becomes less active, and so it is less prone to open. It opens more slowly, and that will decrease our rate of rise in phase 4. And our L-type calcium channel becomes less active. And that's going to mean that our threshold potential is going to become a bit more negative, or a bit less negative, excuse me, a little bit harder to reach, and it's going to take a longer period of time to get there and throw that action potential, okay? Remember, the L-type calcium channel, and to a certain extent the T-type, they carry that upstroke, okay? And so they're going to determine, amongst other things, the threshold potential, or they're going to be part of what determines it. All right? So, when that generated action potential at the SA node can't get through the AV node because of disease, we call that heart block. Okay? First degree heart block is when the impulses get through, but the AV nodal delay is slow, okay? Which means our action potential propagation velocity is slowed. And that means that our PQ interval is prolonged, okay? Or our PR interval, depending upon how you choose to characterize it. Because that interval represents the AV nodal delay. It's where the action potential is in the AV node, your atrium is depolarized, your ventricle is not depolarized yet. That will happen with the QRS, okay? And so second degree heart block is when some of those impulses get through, but not all of them. So as you might expect, the apparent heart rate will be slowed. If you're feeling somebody's pulse or listening for the closure of the valves, you're not going to hear that as often, and it'll be irregular as well. So that would cause a bradycardia. Some of them get through, not all of them get through, okay? And then we have third degree heart block when none of them get through, and in that case, the AV node, whatever healthy cells you have left, it will set the pace at a slower rate, or even worse, the Purkinje fibers will set the pace. Some of them will spontaneously depolarize. They have a phase 4. And that will happen at an even slower pace, okay? The reason why the SA node sets the pace of the heart is because phase 4 in the SA node is fastest. So it hits threshold first. So if I'm in the AV node, the action potential from the SA node propagates to me and depolarizes me before I get a chance to hit threshold on my own. So the SA node sets the rate. When the SA nodal potentials aren't getting to me, then I set the rate whenever I hit threshold, and that's going to be a slower rate because my rate of rise is slower natively, okay? Okay. Automaticity can decrease with sleep, of course. If you're sleeping, your parasympathetic activity is pretty high, sympathetic activity low. That will certainly decrease your heart rate. It'll decrease with age to some extent, and it'll decrease with some drug treatment. I bet you could guess what some of those drugs do, say at the muscarinic receptor, okay? So things to keep in mind in terms of causes of bradycardia is slower or apparently slower heart rates, okay? Calcium channel blockers will actually cause heart block. It'll cause a prolonged PR or PQ interval. Why do you think that is? Anyone? No, it's 8 o'clock in the morning. Go ahead. No? Okay. I saw the hands go up. They're just pointing. I bet they know the answer. They just don't want to. Yeah. Well, what about the upstroke? It'll happen, but it'll be slowed if I block calcium channels, right? So in nerve, if I want to slow the rate of propagation, I block sodium channels, local anesthetic. And of course, if you block them all, then you get no action potential at all. In AV node and SA node, calcium channels take the place of sodium channels. So if I block calcium channels, I do the same thing. They slow the action potential propagation. They increase the AV nodal delay. And they'll cause a bigger PR interval on the ECG. You need to be able to put all that together, okay? I know they came in separate lectures, and one of them came last block, but that's the way we put things together on an exam to answer questions, okay? So we start with calcium channel, we go through the increased AV nodal delay, we go to something that we can actually see in a patient, a prolonged PR interval, okay? In terms of tachycardia, physiologically, again, the sinus node sets the pace, okay, the SA node. So now we have norepinephrine binding the beta adrenergic receptor, primarily beta 1, at the SA node. And that activates GS, G-stimulatory, that stimulates adenylyl cyclase, increases cyclic AMP, increases pKa activity, increases L-type calcium channel activity, and facilitates the pacemaker channel. The net effect being that phase 4 rises more quickly, and our threshold potential might be a little bit more negative and easy to get to because we've facilitated those calcium channels. And not only that, but we expect our action potential propagation to be faster because we facilitated those calcium channels. Effectively, it's the same thing as increasing the number of sodium channels in a nerve or skeletal muscle cell. Okay, it increases the action potential propagation velocity, shortens the AV node, the AV delay, nodal delay. Okay, so you can increase the slope of phase 4 in the SA node as well as the AV node, just like I said. That can happen physiologically. It can also happen to cells in the conduction pathway with disease, okay? And this can be a problem, okay? If it's happening in the SA node due to disease, then you're going to end up with a tachycardia. That's obvious because you're going to have an increased heart rate. If it happens in the AV node and not the SA node, then your AV node is suddenly setting the pace. That can be a problem. And of course, if it happens in disease cells in the conduction pathway, then that can be a problem as well. And of course, we know that those are going to be tachycardias because the SA node is going to be trying to set your pace at a normal rate. And your disease cell is therefore going to be setting it at a higher rate than that, okay? These are called ectopic foci, okay? They're places that are setting the heart rate that are not supposed to set the heart rate. And outside of the SA node, it tends to be the AV node or places in the conduction pathway, Purkinje fibers, okay? And it often is associated with disease, heart disease, okay? These are tachycardias. In particular, those are called supraventricular tachycardias because they're generated theoretically above the AV node. I know the conduction pathway is not above it, but it definitely is above ventricular excitation, okay? So they're called ventricular tachycardias. That's one type of tachycardia that you can run into. Another type is due to triggered activity, okay? And this is different. Triggered activity is due to abnormal action potentials in chunks of tissue. Okay. So we talked about long QT syndrome in workshop, and we said that in theory this can cause EADs, early after depolarizations. Those are depolarizations that come during the action potential when they shouldn't, and they tend to prolong it like this. Okay, that is an EAD. Okay, and this is an EAD. It's the one that we commonly show during the workshop. The second type is a DAD, delayed after depolarization. Delayed because it comes after you repolarize your action potential. So in this case, you get a sudden increase in the membrane voltage, and if that increase hits threshold, you throw an extra systole and an extra beat when you're not supposed to, and that can propagate and cause an arrhythmia because you're throwing a beat when you shouldn't, and it propagates through the heart when it shouldn't. And it throws that whole ordered series of events, SA node through the atrium, AV node, down the conduction pathway and out, throws that whole thing off. When you throw that whole thing off, you tend to end up with arrhythmias, okay? Or at least they're more likely, in theory. Both of these are associated with excessive catecholamine stimulation, and they tend to be more likely to happen during stress. So we'll talk about that in a minute, okay? That's triggered activity. The third type is what's called a reentrant arrhythmia, and it's probably the most complicated. So let's concentrate on the normal situation first. What we have are two parallel conduction pathways that theoretically conduct the action potential at the same rate as should happen, okay? Propagate the action potential at the same rate. So that's the normal. What happens is you have an action potential, it comes down and it splits between these two conduction pathways. They're electrically isolated, okay? But they're propagating action potentials at the same rate, the alpha pathway and the beta pathway, and then they hit some distal section of conduction pathway. The two waves meet and they annihilate each other. So, once you depolarize the membrane, it's refractory, and you can't re-depolarize it. So if two waves of depolarization hit each other, they just depolarize the point where they meet, and then everything stops, okay? That's wave annihilation. And that happens commonly in your heart. It's a normal thing, and if all your tissues are conducting normally, that's just fine, okay? The problems come when you get what are called unidirectional blocks due to disease, okay? That is, the action potential would like to propagate down this beta pathway, but it can't, okay? It's being prevented, usually due to cellular dysfunction or myocardial fibrosis, where you get an altered structure of the conduction pathway, okay? In other words, myocardial infarctions or chronic heart failure, where you tend to get more fibrosis in your myocardium, they can cause this to happen, okay? And what happens is the action potential won't propagate down this pathway, but for some reason that isn't really well understood, it'll propagate back up, okay? Now, if it does that, so we go down the alpha pathway, down our distal site, and then back up the beta pathway, okay, retrograde, okay? So what may happen when you do that is, if you're lucky, the action potential goes right back up the beta pathway, it hits your alpha pathway again, but your alpha pathway is still depolarized and refractory. And if your alpha pathway is still depolarized and refractory, then the wave just stops. It's effectively a wave annihilation, okay? Because it can't go any farther, it's hit tissue that's refractory. It's already been depolarized, okay? So that's the ideal situation where the action potential just stops, no harm done. The problems come when that retrograde pathway is slow for some reason. And again, this is diseased tissue. So it's not surprising, particularly if you can't conduct an all in one direction, if maybe you're slowed in the other direction. This can cause a problem because the alpha branch, if it delays it enough, it will have recovered from its action potential. Okay? And it'll be down and ready to depolarize again. When your action potential propagates back up your beta pathway, it hits that alpha pathway and re-excites it when it shouldn't. And so your action potential can go round and around this pathway, where it goes down the alpha, up the beta, it hits the alpha again after it's repolarized, so it's a re-entrant circuit. And while it's going round and around, it's exciting the tissue around it. Okay? And it's causing an arrhythmia. It's causing excitation and contraction when you shouldn't have that. Okay? So that's a re-entrant arrhythmia. Okay? It's when you get a combination of a unidirectional block on the top and a slowed conduction in retrograde fashion. Okay? So those are three kinds of arrhythmias.